we're actually live. We are now live.
Welcome, and thank you for bearing with us as we continue to manage the logistics around a hybrid meeting. As you can see, we have some commissioners who are in the HPC offices today, and then we want to welcome all of you who have tuned in for today's board meeting through Zoom. I want to begin today's meeting with an important announcement, an introduction. After our last meeting in July, Attorney General Campbell appointed Dr. Alicia McGregor to the HPC board. We're delighted to welcome her to fill the seat for a member with expertise in healthcare consumer advocacy. As you will remember, this seat was previously held with great distinction by Dr. John Berwick. Dr. McGregor is an assistant professor of health policy and politics in the Department of Health Policy and Management and Harvard T.H. Chan School of Public Health. Dr. McGregor is an interdisciplinary scholar with expertise in health systems, health equity, and community health. And I'd like to invite Dr. McGregor to introduce herself and say a few words.
Sure. Thank you so much, Chair DeVoe. Good afternoon, everyone. I'm Alicia McGregor, faculty member in the Health Policy and Management Department at the Harvard Chan School. It's truly an honor and a privilege to join the Health Policy Commission's Board of Commissioners. As Deb mentioned, my work is interdisciplinary at its core, like I think all health policy work is. But over the last several years, it has fallen under the umbrella of the political determinants of health and health policies, with a specific focus in the last few years on how changes in the health system or the types of business decisions that hospitals and hospital systems make, how these changes come to bear on the health of communities. And my research team have been focusing quite a bit on how obstetric unit closures impact health equities, health inequities in maternal health. So definitely a lot of the work that I do every day is right in line with the work of the Health Policy Commission. So I was delighted to apply for this role, and I'm most delighted to be here today and for the work ahead. So thank you so much.
Thank you and welcome. So now to move to our agenda for the day, we have several important agenda items to cover. Our first topic will be a presentation on site-neutral hospital outpatient payment policies. Dr. Auerbach will provide an introduction to the topic, and then we will hear from guest speaker, Lauren Adler, who's the Associate Director at the Booking Schaefer Initiative on Health Policy. Looking forward to that. Next, Executive Director Seltz will review the final policy recommendations for the 2023 cost trends report, and we'll take up the vote to issue the report from the Commission today. Then we'll hear an update from the HPC staff on our agency's work to integrate the health equity lens into our work streams. And finally, Executive Director Seltz will close out the meeting with his Executive Director report. So our first action will be to review and vote on the minutes from our last board meeting from July 12th, 2023. And can I turn it over to Lois Johnson, our General Counsel, to handle the vote? Thank you, Chair.
So, on the slide is the motion. Can I get someone to move the motion?
So moved.
Second. Any addition or changes to the minutes? Hearing none, I'm going to call each commissioner present for their vote, starting with Chair DeVoe. Approved. Chair Cullen.
Approved.
Commissioner Blakey. Commissioner Blakey. Zoom. come back to Commissioner
She's on
Blakely.
mute.
Commissioner Pascal?
I'm sorry, I'm having a difficult time hearing you. I missed what you were saying.
If you can hear me now, I'm asking for a roll call vote on the minutes. Do you
Okay.
have the minutes?
Yes.
Going
Approved.
back to- Thank you. Commissioner Blakely? Can you hear me? Commissioner Cutler?
Approved.
Commissioner Hought?
Approved.
Commissioner Master Giovanni?
Approved.
Commissioner McGregor? Abstain. Commissioner Kwasnick? Commissioner Kwasnick? Folks are having trouble hearing. And I believe Commissioner Walsh is on the call.
Approved.
Thank you. And that, those votes, chair to vote, approve the minutes.
Coming through. I'm not sure
Thank
why
you so
Barbara
much.
can't hear.
And for commissioners, feel free to type in the chat if you're having any difficulty hearing, and thanks for helping us fine-tune our technology. Next, we'll move to the presentation on site-neutral hospital outpatient payment policy. And let me introduce Dr. David Auerbach, our Senior Director for Research.
This is Kate. I'm sorry. It's really, really hard to hear you. I don't know if it's my advanced age, which I'll stipulate to, but
Thank you, Secretary Welch. Is this better?
I think maybe if Dr. McGregor could mute while you're talking and you could mute while she's talking, I think your mics are interfering with each other, but that's my only diagnosis. Thanks. Sorry.
Thank you. I'm so glad this is in your job description. I know you have a few other things to think about too. Is that better? Okay. No, we're going to ask if we can take a break, try to fix this, and we will come back online as soon as we've worked out the last one.
For our September board meeting. As you've already seen, we are really experimenting this meeting with a new hybrid model for being able to conduct the important work of the Health Policy Commission, and really do appreciate your patience as we work through some of the new technical capabilities that we've put in place. This is a learning experience, and we will continue to improve. But please feel free to put into the chat and let us know at any point if you have difficulty hearing or participating, and raising your questions and comments. We have a really exciting agenda for today's board meeting today. First of all, I hope everyone had a wonderful summer, and this kickoff to the fall. To kick off this fall and to kick off this meeting, we first wanted to revisit a topic that has been part of the Health Policy Commission's policy recommendations for a number of years. This is a topic that often we talk about with regard to the placement of facility fees on certain services provided in hospital outpatient departments. But this topic has grown in interest among policymakers, and the concept of facility fees is really much larger in thinking about the opportunity for site-neutral hospital outpatient payment. So to revisit this topic and to give you board members an update about some of the interesting policy developments, both at the federal and state level, we've invited a guest speaker here this morning. And before that, I am excited to turn it over to Dr. David Auerbach, the Director of Research and Cost Trends at Health Policy Commission, to just give us a little bit of a background on the work that the HPC has done relative to this topic before turning to our esteemed guest. David, take it away.
Great, thank you, David. Can you hear me well? Okay, all right, let's go. Okay, so I'm just going to give a few slides of introduction and some of that Massachusetts-specific context before turning it over to Lauren Adler. So on this first graph, I'm showing for several common services, the distribution of where they are performed in Massachusetts. And we're talking about the commercial market here. And so if you think of imaging, tests, clinician-administered drugs, and lab services, you can see that these are provided across an array of settings. And the HOPD, the hospital outpatient departments in the dark blue, are around 50% for all of these services. But these are routine services that are pretty much the same regardless of site. And I will note that the HOPD share is high in Massachusetts, as we show in the cost trends report in a number of cases. It's particularly high. And in some of these cases, growing. The HOPD share for clinician-administered drugs was 60% in 2017. The next slide, please. So even though the services are pretty much the same, the payments are not. Payers typically pay more for the same services when they're in a hospital outpatient department. In some cases, this includes both a professional fee and a facility fee. And why? Why are we paying more? There's a number of reasons. Partly it's that the hospitals tend to have more market leverage, and partly there is a practice that makes sense in some contexts where, for example, an emergency department has higher fixed costs and higher overhead, and it makes sense to pay more. There's more resources used, even if it's the same service that might take place in an office. But again, this doesn't really apply for things like labs and clinician-administered drugs, where it's pretty much the same service and the same resources regardless. So Medicare does pay site neutrally for some things, administered drugs, labs, mammography, for example, and some evaluation and management visits. Although commercial payers typically don't. They pay differentially for all of these services for the most part. And even though Medicare just does that in some cases, there's a lot of momentum, which Lauren will talk about, to try to expand that. And MedPAC has for years recommended that Medicare expand this to additional services like imaging and skin and nerve procedures, tests, endoscopies, and things like that. So on the next slide, we'll just review, and Lauren will talk about this again, I think, some of the problems with these payment differentials. First of all, we're paying more. We pay more in premiums, and consumers pay more out of pocket. That's number one. You also are providing an incentive for hospitals to consolidate other services under the hospital umbrella and to expand, because the payments there are higher. And when that consolidation happens, as we know, that tends to lead to price increases across all of healthcare with the greater degree of market power. That's just vertical integration and consolidation. We see that everywhere. And this is particularly a case in Massachusetts. We have a much higher utilization of hospital outpatient visits than most other states. And this is the biggest category of spending that's responsible for our spending. So on the next few slides, I'll just give you some examples so you can see how these prices differ. Here's an example of a basic lipid panel. It's not that expensive in itself, but these add up. You can see on the bottom the prices paid when this occurs in the hospital outpatient department. An average of $30, but the 95th percentile you see there is $73. So that means that 5% of the time, more than $73 are paid for a lipid panel. When this is performed in an office, it has an average of $17, an independent lab, $14, and Medicare, as we noted, pays the same regardless of site, $13 on average. Next slide. And that was an example of one lab, and as I've shown this before, when we combine the top 50 labs into a market basket of lab services and array them like this, you can see quite clearly that the blue bars are higher. That's when these lab services are performed in a HOPD. The blue bars are all higher than the yellow, the independent labs, and the orange in the physician offices. And not only that, there's a lot of variation across the blue bars, and that is reflecting different things about the hospital's pricing power and market leverage. And a final thing to note on this slide is we've shown the cost sharing amount in the lighter shading on the bottom of each of these bars. And you can see that the cost sharing varies pretty much proportionally with the total payment and the total price. Okay. Next slide, I'll just give a couple other examples. An abdominal CT scan on average was paid $1,300 when performed in a HOPD, with a 95th percentile of $2,800 compared to an office average payment of $800. And you see the Medicare does have a differential there. They are both quite a bit lower than the commercial prices. And finally, we'll show a common, on the next slide, clinician administered drug. There we go. Neulasta, which is usually delivered in the form of a patch to reduce infection after chemotherapy. Average price when this is in a Hop D, $6,300, with a 95th percentile of $12,800, compared to around a $3,000 average price when this happens in an office, and similar price for Medicare. So those are just some examples, but these differentials are typical across services. Okay. So now I'm going to introduce Lauren Adler. He is and he'll probably cover some of the same ground, but more as well. A fellow and associate director at the Brookings Schaefer Institute on Health Policy, Initiative on Health Policy. Currently a member of the advisory committee on ground ambulance established by the No Surprises Act, and he has testified before Congress on site neutral payment. His research also includes topics such as private equity, provider consolidation, surprise billing, and prescription drug medicine. All topics that we are very interested in here, and maybe we'll have you back. So thank you very much.
Great. Thanks for having me. Am I coming in clearly on your end? All right, perfect. All right, so thank you for the introduction. I think that covers it. Yeah, so my name's Lauren Adler. I'm out in DC at the Brookings Institution, and I'm going to talk a little bit about sort of site neutral hospital outpatient payment policies, both sort of from the federal level, so focusing mainly on Medicare, and then a little bit from the sort of state perspective here as well. Touching on some of the same things that David touched, but more focusing on kind of the policy levers that could plausibly be pulled here. So jumping to the next slide, or the first slide here, I think just sort of first and foremost, right, kind of what is the problem? What's the issue here? And I'm, starting off focusing kind of on Medicare, where right in Medicare, we have administratively set prices. They are, they're sort of immovable, and right. So the way Medicare is structured, Medicare pays more money for the exact same service if it is done in a hospital outpatient department rather than an ambulatory surgery center or a physician's office. And on average, the last time sort of did this across a bucket of services, on average, it's about twice as much. Medicare's paying double, for the same service in a hospital outpatient department than a physician's office. And so here's sort of like the one example that MedPAC, a federal commission on Medicare, highlighted is for a level 2 nerve injection. So here we're looking at an example where if that service is done in a physician's office, Medicare would pay a total of $256, of which the patient's responsible for $51. Or that same exact service is done in a hospital outpatient department, the total bill is $740. And the patient's paying about $150. So in this case, right, it's both the patient liability and the total, sort of bill to Medicare here is triple actually, in the hospital outpatient department versus the physician's office. And I think there's a good paper by Brady Post, Tom Buckmuller, and others that tries to sort of summarize how much money this sort of means at a more aggregate level. And back in 2016, the sort of doing the same set of services in a hospital outpatient department rather than a physician's office means about $150,000 per doctor per year more in Medicare revenue. So right, that is just a very big incentive, a very big difference that we're talking about. Jumping to the next slide here, I just want to sort of drive home, like, why is this an issue, right? I think first and foremost, there's just sort of this question of, right, paying more for the same service often makes little sense, particularly for the types of services that are delivered in physician offices. So we're talking mostly about office visits, imaging, drug administration. And when you're talking about those sort of lower complexity services, it's hard to justify why Medicare should be paying such disparate amounts here. And in MedPAC, in their most recent work, also tried to sort of drill down on some of the arguments that get thrown back from kind of the hospital side of things, pushing back on this. And right, hospitals will say, look, we're treating just sicker patients. We're treating more complex patients. Of course, it costs us more to do the same service. We should be paid more for that same service. However, right, when we're talking about these lower complexity services, so MedPAC actually took a look, and the sort of the severity of the patient or the complexity of the patient here was actually very similar for patients who were treated in physician offices or in hospitals. And I think even really more damning to that sort of hospital argument here is within hospital outpatient departments, if you look at sort of all of the same service that they do for, sicker versus less sick patients, they're not charging they're not charging any more for the sicker patient than the less sick patient, which implies that there's really not actually at least more than a marginal cost difference here. And jumping to the next slide, right? I think I touched on this at the beginning, but right, a big effect here is just, right, this means higher cost sharing for patients. In Medicare, patients are liable for 20% in general of the sort of total Medicare rate. Yes, some folks have supplemental insurance, but that means then they're just paying higher premiums for that supplemental insurance. And also, right, it means higher Medicare premiums. And right, Medicare is largely subsidized by taxpayers, so it means higher taxpayer spending. And as I sort of touched on the first slide, but right, this creates a very large incentive for hospitals to acquire physician practices, or sort of the flip side for physicians, just, you're deciding which job to do. It provides, there's just a lot more money floating around in the hospital pot here. So it creates an incentive for physicians to just choose hospital employment rather than independent practice. And this is just sort of the point I was trying to drive home earlier, right? It's $150,000 per doctor per year. That's 2016, so that is almost certainly more if we're talking about today's dollars. On top of that, right, this is something that we expect Medicare's policy to be having pretty important spillover effects to increase the sort of costs in the commercial market. And really that's sort of two main reasons. One is, right, we have a lot of evidence now that this vertical consolidation between when hospitals are buying up all of the physician practices, that tends to increase costs for commercial payers and patients. And some of that is, the hospitals just buying the practices. Some of it is, the hospital buys 20 cardiology practices in the area. That also consolidates the cardiology market there. And we think increases prices without commensurate increases in quality. And then there's just also another body of evidence that basically shows that when Medicare reduces what it pays for a service, you basically, you tend to have a spillover and decrease what commercial payers pay for the service as well, largely because you've sort of lowered how much you get from Medicare. So you're willing to get commercial patients in the door rather than Medicare. You're now, as the provider, willing to take a little bit less money because Medicare is less lucrative. So, just driving home this point on the next slide here of the sort of hospital acquisition effect here, right? If you're looking at kind of all of the factors pushing towards hospital acquisition of physician practices, I don't want to pretend that site neutral payment is the only issue, but it is almost certainly a very sizable one, given that payment differential and the sort of amount of dollars at stake here that we were just talking about. And so it's unsurprising that we have seen this very large shift of the share of doctors who now work for a hospital nowadays. All right. So this is a strong encouragement to sell your practice to the hospital. And right, we see this, this is sort of all specialties lumped together. On the next slide here, we just break it down and show that this is right. You see this across specialties. It tends to be specialties that have a little bit of hospital business, or sending patients to the hospital here. You see dermatology a bit lower, but it is pretty much across all the specialties. We're seeing this very sizable trend towards vertical consolidation here, and sort of hospitals becoming the kind of main employer of physicians. And jumping to the next slide, right? This is sort of, rather than thinking about this as necessarily a sort of the consolidation angle here, we also see this in the data, and this kind of jives a little bit with what David was talking about earlier, right? We have seen, this is the sort of comparing 2012 to 2021. We now see a substantially higher portion of some of these lower complexity services that are happening in a hospital outpatient department rather than in a freestanding physician's office. So, right, the sort of chemotherapy administration has jumped from about 35 to 50% of those services are now happening in a hospital. Similarly, we've seen about a 33% increase in how many sort of physician office visits are happening in a hospital outpatient department. So now I want to kind of turn to the policy, the levers here to kind of tee up things. One, right, I think this is interesting at the federal level. This is we've been actually having a substantial amount of debate in Congress this year on this issue. Really the first time since a tiny provision snuck into a 2015 bill. But just to tee things up a little bit, I kind of just wanted to talk about sort of the broad categorizations here of the types of proposals. Happy to kind of dive in if folks have questions either on here or in follow-ups on, on specific proposals that are out there. But it's sort of everything's moving pretty quickly right now because technically there's sort of a September 30th deadline that folks are working around in Congress. But by and large, I mostly want to focus on this first category because that is really kind of this is the big policy. So again, keep referencing MedPAC, who's sort of been, right, is the Medicare Payment Advisory Commission. Federally, they're non-governmental, but they tend to, sort of like this commission, provide advice to the federal government on Medicare policy. They have for a while now been at least discussing this proposal to equalize Medicare payments for a set of lower complexity services that they identify, and that would be across hospital outpatient departments, ASCs, and physician offices. Some of the bills out there would also extend this to freestanding emergency departments, cancer hospitals, and sort of other types of facilities as well. But right, now you're kind of talking about a bucket of services. You're identifying these are the services that are kind of lower complexity, where we don't see sort of differences in the severity of patients, or where that shouldn't really affect the cost of doing services, right? Like doing an MRI on a patient isn't any more difficult necessarily just because the patient is sicker or isn't more costly, right? This is the proposal that, right, this is a lot of money we're talking about. This is, in federal budget land, you're kind of talking about $150 billion of savings over 10 years. It's just sort of an order of magnitude more impactful than any of the other things I'm going to talk to. So I just want to highlight that point that kind of really is. And from a policy perspective, right, you're kind of focused on the types of services here where payment alignment makes sense is sort of the most logical. The second bucket here tends to be where most of the action federally has been so far. And this basically would just do this payment equalization toward the physician fee schedule only for services at what are considered off-campus hospital outpatient departments. So this is generally has to be a certain amount of miles away from the hospital's main campus. The reason this sort of gets a lot of attention is often these are literally hospital bought a physician practice, didn't change anything, just hung their banner on the door. It looks exactly like a physician office. There's some great quotes of, hospitals emailing their patients being like, look, everything's going to look exactly the same to you. Treatment's going to be exactly the same, but now Medicare's paying 2 or 3 times as much. And right, so that seems to be where a lot of the proposals are. And again, obviously you can do that broadly to all services at off-campus HOPDs, or you can sort of narrow in at, pick your bucket of services. So already for office visits, for instance, there already is payment equalization off-campus. The current proposal that seems most likely to pass Congress this year sort of extends that payment equalization just to drug administration services. So just that sort of the payment for administering a drug in a physician's office. And then there's this sort of bucket 3 and 4 here are services that are more focused on the commercial market. So one is just, there's been a lot of reports of commercial payers having difficulty identifying whether a bill is coming from an off-campus or on-campus hospital outpatient department. So basically there's a federal proposal that would just say, we're going to require the off-campus departments of hospitals to bill under a separate provider identifier. And in some of the bills also to use use the professional billing form here. There's a lot of state proposals along these basically same lines as well. But the idea here is to basically help commercial payers know what's off campus versus on campus. This is over the long run, unclear how much this is really doing, but probably helps over the short run, sort of help the negotiations run a little bit more smoothly in the commercial market. And then lastly, just because this was in a proposal by Bernie Sanders, who's the Health Committee chair in the Senate, he had one proposal here that would actually be to limit the combined facility plus professional fee that can be billed to commercial payers by hospital outpatient departments in the commercial market here for a set of services here. And that one, right, that is a form of price regulation in the commercial market. Not sure that has a ton of legs federally, but I want to throw that out there because I think that is sort of, if you're looking for cost savings, like overall cost savings in the commercial market, that's probably your biggest lever there. Jumping to the next slide, just wanted to kind of give a sense of what we're talking about when I say lower complexity services here. That's pretty vague. To give kind of a rundown here, we're mostly talking about three categories here. It's clinic visits, and then it's imaging, and then drug administration. Those are really kind of the three big lower complexity service buckets that we're talking about, where sort of payment equalization might make the most sense. And then lastly, I want to close with sort of the state discussion here, where this overlaps a fair amount with the federal proposals I just teed up. If we could go to the next slide. But right, so again, two of these are identical to the last ones we were just talking about. So again, a number of states recently have sort of moved forward on this proposal to require off-campus departments of a hospital to use a separate provider identifier or specific forms to bill a commercial payer. It often gets called like fair billing proposals. It's just sort of the name nomenclature. Number two here, which has been happening also in states recently, is a move to prohibit or limit facility fees, just like whether you can charge a facility fee at all for certain hospital outpatient services. And just as sort of the other proposals we're talking about, this could apply kind of to all hospital outpatient departments. It could apply to all off-campus hospital outpatient departments, or honestly, you can pick and choose. Some states have said, okay, for preventative care service or for telehealth services, and that sort of lever here, right? This may have some sort of simplicity benefits here for the patient who, right? I think you often hear the case of the patient who is going to their doctor one day in a physician's office. They're getting charged this sort of professional fee, and then the practice gets bought by a hospital. They go back 2 weeks later, and all of a sudden, on top of the professional fee, they are also getting billed for a facility fee. And there's certainly a sort of glaring unfairness to that patient in that situation. So it definitely helps address that. I think it's hard to envision this having too much of sort of a broader, sort of healthcare costs overall effect here, right? Because fundamentally, you're not sort of changing any of the relative leverage between the hospital and the insurer here, right? You're just sort of telling them how to bill. I always liken this to, right, if you put a regulation on airlines to say, okay, you can't bill you can't charge separately for baggage fees anymore. Right, we don't all think that like plane tickets are just going to like be $50 cheaper across the board, and we're just going to pay $50 less, right? They would sort of try to rejigger their pricing to just the same, try to get towards the same revenue, in the kind of overall fee. And then lastly, again, I don't need to retouch on this too much, but right, if you are trying to get at the cost saving side of things here, you really do need to kind of come in with some sort of actual limit on the sort of combination of the facility and professional fees. So sort of like the total bill, right? If you just said hospital outpatient departments can't bill more than sort of the average physician practice costs or a percentage of Medicare, then yes, then that fundamentally changes the leverage and sort of gives the commercial payers more leverage in these negotiations. And on that, I will close. And if I have questions or whatever the next steps are.
Well, thank you so much for your presentation and for bringing us up to speed on this topic. I think what we wanted to do now was to actually pull down the slides and allow for some conversation among commissioners and with our guest speaker and with David Auerbach. Comments, questions, thoughts, and reflections while we have this great expert with us on this topic. And as you said, a lot of interesting activity, both at the federal and state level. I will share with the commissioners that Connecticut recently did pass legislation that would prohibit facility fees in the case of basic office visits, as well as telehealth visits. So we have heard of a case, and this was a recommendation in our telehealth report, where patients were receiving a facility fee charge based on a telehealth visit, which was billed through a hospital outpatient department. Of course, that patient didn't go to the hospital outpatient department. So there is some activity in other states thinking about how to deal with this policy issue, but also to deal with it in a way that reflects that this is an important revenue stream for hospitals. And so how do we manage the right sizing some of these incentives, understanding that these have been in place for quite some time. So I'll stop there and really interested to hear from other commissioners.
I had a question for Lauren. It was a really interesting presentation. In the states where this has been attempted, have we seen any change or improvement in access? Because one of the things I think about is, there's a year-long wait across our state for certain procedures, many of which were on the slide. Wonder, are there any unintended consequences? The savings are obvious, but what would you worry about if we were to do something similar in our state?
Sure. So I don't think we have any sort of hard evidence on the access effects of any of these proposals, of these policies yet. Some of them haven't been in effect terribly long. At the state level, the policies we're talking about also shouldn't actually be affecting hospital revenue. So it'd be you wouldn't expect any, right? Because again, that's the sort of dynamic of you're not changing the relative leverage. So you should just sort of changing how the thing is getting billed. So there's no reason to expect any revenue reduction. So you wouldn't expect any access effects. But it's also notable we haven't really heard anything about a peep out of on the federal level where there really were revenue reductions. So there was a law passed in 2015 that did do payment equalization in Medicare for all off-campus services. They grandfathered in, well, I guess they did grandfather in a lot of people, but in 2019 they extended that and kind of got rid of the grandfathering, and that we haven't heard any access issues stemming from that where there really was a revenue reduction happening there. But again, right?
Well, we have access issues. It's not clear where they're stemming from, I guess.
Yeah, sorry, not increased access issues, I should say. Sorry, not that there are no access issues at the baseline.
Thank you. And as a follow-on question to Secretary Walsh, can you say more about the experience at the state level, whether states have used different approaches as they've moved to eliminate facility fees or, as you said, to handle facility fees in a different way?
Sure, yeah. I mean, so broadly, there's sort of the two main approaches that we've seen. So one is just this require hospital outpatient departments to be very clear effectively when the bill is coming from an off-campus department. So Indiana, for instance, recently passed a law along those lines. I think Colorado has a law to that effect. I'm never going to get every state's laws perfectly here, but there have been a number of laws on that towards that end. That one, I think, right, it's sort of a transparency-esque type of proposal here, right, where you're just saying you need to make it clear who's actually doing the billing. It's a little harder to argue against. On the sort of facility fee banning side, I think we've seen a few options here. So I think it's Connecticut and New York have tried addressing sort of broadly the kind of clinic visit type of services here to say no facility fees. And then a number of states have tried to get at telehealth. I mean, obviously that's sort of become a big thing. And one of these things, I think, to your average consumer who hears that you're charging a facility fee for telehealth, it sounds a touch jarring. So it tends to be politically easier, I think, to kind of get that, and probably more of I think there is sort of a fairness rationale when you're talking about that, but we really haven't seen much in sort of the way of what are the kind of knock-on effects of some of these proposals here.
Thank you. Other commissioners, any questions for our speaker? Oh, great. Ron?
Thank you. Lauren, excellent presentation. Appreciate it. I was wondering from a cost sharing perspective, from Medicare patients' point of view and utilizing a hop D, is there a variance in cost sharing between a patient with Medicare B coverage versus Medicare Advantage? Is there a significant difference in cost sharing?
I mean, it depends slightly on what your Medicare Advantage plan is to be upfront, but in general, cost sharing in Medicare Advantage tends to be slightly lower on average because they're basically being thrown extra federal subsidy dollars. So they tend to buying down your cost sharing a little bit on average. But overall, sort of the base package of Medicare Advantage is supposed to be equal in terms of cost sharing, and then they sort of add buy downs on top of that. There's obviously going to be exceptions, for individual services when you're talking about things, but in general, cost sharing is slightly lower, but not probably not, terribly so for these services. I think a big thing in Medicare Advantage, you also have a limit on how much you can owe in a year, basically a maximum out-of-pocket limit in Medicare Advantage that you don't have in traditional Medicare unless you're also buying a supplemental Medigap plan.
Thank you.
Commissioner Houdt?
Yeah, what strikes me through this conversation is, we recently passed the No Surprises Act, and you think that did away with a lot of this surprise billing, but surprise, you now have a hospital outpatient fee associated with your office visit or even your telehealth visit here. So I guess I'm coming at it from a consumer advocacy point of view, and the fact that if I go to my orthopedist and she said, you need an MRI on your knee, and you can go make the appointment as you're leaving, and obviously they'll send you to the hospital. And I think here in Massachusetts, people are aware of some freestanding facilities that offer MRIs of high quality that cost significantly less because advertising has put that message across. But it's really true for any number of services, and patients don't realize that they have a choice. And I think that's the problem. They don't either know to ask the question or don't realize they have a choice. And maybe now they have less choice because their physician's practice has been bought by the hospital and that choice no longer exists. So I think fundamentally that's the problem that I'm hearing as I'm listening to your presentation, which makes some excellent points. And I'm all for this cost neutral pricing.
And there's also, right, I think there is a version of what we're talking about here that looks very similar actually to the sort of canonical surprise out of network billing issue we talked about, right? Because in that case, it's almost, we're all talking about the facility is in network, but the clinician is out of network. Yes. In this situation, you could end up with the opposite, where your clinician's in network because you've been going to them forever, and then you didn't even know there was a facility involved, and it's plausible that the facility is not in your insurer's network, and then you could be liable for a balanced surprise bill from the facility. That's like less common than the reverse, but there's going to be instances where that happens.
Yeah. Thank you.
Commissioner Cutler?
Thank you. So, Lauren, thank you for the presentation. There's no one who has a substantive rationale for this policy. Like, you can't come up with anyone who says, "Oh, here's like a good reason for it." So in my mind, this is one of those sort of dumb things that we really ought to get rid of. So I have just one comment and one question. That the question is, if maybe for Lauren, but or maybe just for all of us, which is, if you had to think about this at the state level, which way of addressing this would you think might be most effective? But the comment is, I don't see any rationale for doing this, for getting rid of it for just some services, like, for just patient visits or just drug. Like, if you think the thing is bad, get rid of it. And if you think you need a transition period, then fine, put in a transition period where, you're going to eliminate it over 3 years or whatever. But like, I can't understand a rationale for saying, well, I'm going to eliminate it for drug administration or for visits, but not for something else. Like, that doesn't. And I understand people do these sort of compromise things, but that just doesn't strike me as doing anything substantively good here.
I mean, I'll just take a first crack. Other people can obviously jump in as their thing, but at the state level, I like the biggest lever here is Medicare, which obviously isn't state's purview here. I haven't really looked that closely at it. It is possible. I mean, I think this issue does exist in some state Medicaid programs, which obviously has a lot of state dollars flowing. Of the sort of other proposals we talked about, I think sort of the sort of forcing people to bill accurately is probably kind of the simplest way to kind of get at some of this. I think there's a consumer protection rationale to some of the other stuff. But as I was saying, the commercial market stuff, unless you're coming in and really price regulating, which is a little harder of a lift, obviously, I think it's harder to imagine as much of sort of a cost effect at the state level. To your second point, I certainly like off campus. It seems like kind of like, why on earth would you do this for some services than others? I just like to, the argument that gets thrown out is, take like a complex surgery on campus at a hospital outpatient department where maybe there actually are sort of, something where the sort of 24/7 standby capacity and those sort of things actually is sort of a meaningful difference for the patient, which I think is why MedPAC has sort of focuses on this. I think they're probably being too conservative, in my opinion, on like what are the bucket of lower complexity services where this makes sense. But I see the argument for there are some more complex services where where I really would prefer to be in a hospital rather than a freestanding physician's office without access to an ED in case things go wrong.
Lauren, great presentation. Thank you. I'm wondering if there's another piece of this. In Massachusetts, we've seen lots of requests to develop off-campus hospital outpatient departments under the guise of convenience. What do we know what the capital expenditures have been for either acquisition, construction, that the sort of ability to add a hospital outpatient fee has added to system spending overall?
That's a good question. I don't have any sort of hard numbers on, the capital expenditures happening. I mean, often they are just buying a physician practice and throwing up a label on it, but certainly you're increasing, right? When you pay more for something, you get more of it. So, right, you are paying more there, like you've created incentive for hospital outpatient departments to pop up, right? In some areas, like freestanding emergency departments popped up with a similar rationale. I mean, right, it's $150,000 per doctor per year more. That's a lot of money, right? So you might it is in the hospital's interest to try to get that money. And that is really just an artifact of what I would consider sort of a payment loophole in Medicare, or kind of dumb Medicare payment policy from a long time ago that is very hard to fix politically. So, certainly that incentive is clearly there, but I don't have any sort of hard numbers, unfortunately.
Commissioner Foley?
Thank you, and great presentation. Good afternoon, everyone. And that was a really great question that my fellow commissioner just raised. In particular, we know that where these outpatient services are being developed in surgical centers and else is in the more affluent communities throughout the Commonwealth as well. So I do think the Secretary's question about access is one to keep in mind in this discussion as well. Just coming from the consumer perspective on this, and I can understand there's the cost sharing, there's lots of savings, but if we were going to take on, particularly at the state level, a significant policy that removes a lot of money from the systems, there will be savings. And how can we assure that those savings are going to the consumers within the healthcare system versus other areas of the system?
And that's a good question. I mean, right, there are medical loss ratio regulations on how much of the premium dollar has to be spent on claim spending versus premiums. I mean, I'll just say we have a pretty strong body of evidence now that sort of the healthcare costs and, for instance, employee wages tend to move together. There's, 2 recent papers right now showing that when hospitals consolidate, prices go up and wages go down 1 for 1, almost basically 1 for 1. Right. This is the same dynamic we're talking about here, that if you are actually lowering the sort of cost of the overall service here, you'd anticipate, I mean, right, it's mostly employer plans really, but there's individual market stuff on individual markets a little tougher because the federal government's picking up the marginal dollar of a lot of the premiums there. But in the employer market, you feel pretty confident that this would flow through to employers and in turn into employee wages.
Thank you. Just to add a comment on that final point that Commissioner Foley is raising, even if the solution to eliminating the facility fee for certain services is to take the baggage cost, as he was giving the example, and put it into the plane ticket, or take the cost of the facility fees and put them into a different place in terms of hospital reimbursement, that would still eliminate the differential for consumers, where consumer A gets the service in one location and doesn't have to absorb the cost, and consumer B gets the service in a different location. So I am also very supportive of that solution that doesn't actually generate cost savings to the overall healthcare system, but does make it similar for consumers so that they're not left with the issue that Commissioner Haupt was raising, which is no knowledge that you had a choice to go to a place where you wouldn't have the facility fee, but then you're hit with part of that cost. So I think the two different possibilities, one, a true savings to the healthcare system, which would obviously be a plus, but the other where it's more of a consumer protection. Other thoughts, comments, or any other questions for our presenter? Great, well, thank you so much. Really appreciate the discussion about this issue. It's one that we have great interest in continuing to bring to the forefront for both public understanding and for potential action. So thank you.
Yeah, thanks for having me. And anyone feel free to follow up if there's anything else you're interested in.
Great, thanks so much. So we'll now turn to our next agenda item. I want to introduce the discussion of our 2023 Healthcare Cost Trends Report by thanking the HPC team, who, as always, has done tremendous work to both lead the commissioners through process to understand the report, review, comment, and then to absorb those comments. So I look forward to our discussion and then bringing the report to a vote for approval.
Great. Thank you, Chair DeVoe. Thank you, commissioners. And just to put one final bow on the previous conversation, which I thought was just a great presentation from Lauren. Thank you. I think what really came through for me in that conversation was that there are potentially multiple different policy goals that one could emphasize in thinking about site neutral payment or removing facility fees. Is it around driving cost savings to consumers? Is it around kind of avoiding out-of-pocket differential and that surprise bill on consumers? Is it about removing this market incentive for consolidation and acquisition into bigger systems? And I think one can think of different policy approaches that may balance all of those different goals in different ways. So more to come on site neutral payment as we begin to talk about our recommendations. But first, I am just so thrilled to be able to introduce this, our 10th annual Healthcare Cost Trends Report. The Healthcare Cost Trends Report, Annual Cost Trends Report, is the landmark publication of the Health Policy Commission every single year. This is a requirement of our enabling statute as passed in Chapter 224 of the Acts of 2012, and is intended really as an annual statement of our analysis of spending trends, a deep dive investigation into opportunities and challenges within our healthcare system, and finally, our set of policy recommendations to help guide the work of both the Health Policy Commission, the healthcare marketplace, the legislature and the administration, policymakers, and others to be able to continue our work in making healthcare affordable and equitable and accessible in Massachusetts. We have returned this year in our report to one of the topics that was in the initial first year's report, which is around being able to quantify levels of excessive spending to try to understand our opportunities within our healthcare system to remove some areas of spending or moderate spending that would not directly impact cost, quality, and access. So we've looked at things such as excessive pricing, excessive utilization, facility fees and site of care that we just talked about also falls into some of the analysis that we did this year. In addition to the full report and to the policy recommendations contained therein, we also released a number of accompanying materials at the same time. So we have a pretty significant graphical chart pack that updates analyses that we've conducted every year, and sometimes we'll add some new topics to that. And then in the past few years, and we'll demo this for you in just a minute, we've created an interactive website functionality for the public to be able to go in and look at our findings and our analyses as well. So we have been presenting our findings on this report throughout calendar year 2023. We began really starting to release some of these findings in June, or actually in May, and throughout every one of the committee meetings and board meetings throughout the spring and summer, we have been presenting on the different topics and analyses that are included in the report. So for the presentation today, I'm not going to be focused on the findings and analyses as we've discussed them at many previous meetings, but we'll want to return to the policy recommendations, which we discussed at length at the last board meeting, but want to present the final version for your consideration today. Before we turn to the policy recommendations, I do want to just have an opportunity to show off a little bit, because this work is led by an incredible team, our research and cost trends team, who, in addition to doing groundbreaking novel analyses of very complex healthcare data, have also been really interested in how can we make this information more accessible to different audiences and to the public. And so I'm going to ask to briefly just demo to you a little bit of what the interactive website is going to look like. And so what people can expect when they come to our website and want to engage with the report and the findings. So we're going to pull down the slides again, and we're going to have two of our staff members be able to kind of showcase a little bit of how this is all going to work. First is Diana, and then Leiden from our research and cost trends team to just do a little demonstration of the interactive dashboard.
All right, great. Thank you so much. I hope you can hear me. Please just give me a moment to share my screen. All right, great. Good afternoon, commissioners. I'm pleased to be sharing with you this afternoon the interactive data overview for this year's cost trends report. This interactive overview showcases a selection of exhibits from the report and the chart pack in an accessible manner that encourages exploration of the data. For the next few minutes, I'll preview some of the features and highlighted content of the interactive overview, but encourage all to take a look on their own. And as a note, this year, as last year, we also have a mobile-friendly version of the interactive overview available to continue to encourage data exploration and interactivity. So when the user first opens up the interactive overview, they're presented with an exhibit from the report highlighting the annual growth in total healthcare expenditures per capita in Massachusetts. Each exhibit is accompanied by 2 or 3 sentences that highlight key points or findings from the exhibit. One functionality of note in the interactive overview is a hover over functionality that provides a narrative for each data point within each exhibit. Also included in this hover over are notes and sources for the analyses underlying each of the exhibits. The user can switch between different topics using navigation on the left-hand side of the interactive overview. So for example, when the user clicks on ED boarding, they're shown an exhibit from the chart pack that shows the % of behavioral health related ED visits that resulted in boarding by age between 2020 and 2022. This exhibit is a good example of how the interactive features of the overview encourage data exploration, as the % value for each data point is made available for the user. So for example, if a user is interested in what % of these behavioral health ED visits among individuals aged 65 plus resulted in boarding, they can see the % in both July and August of 2021. And calculate a percentage point difference from there. The last feature that I'd like to highlight are these 4 buttons in the upper right-hand side of the interactive overview. These buttons allow the user to open up PDF versions of the cost trends report, chart pack, policy recommendations, and dashboard in their internet browser. I won't demonstrate that at this moment, but just wanted to highlight that we included it as a feature to allow users to explore not only the breadth, but the depth of the cost trends report. And now I'll pass it over to my colleague, Leiden Marcelat, who will be sharing this year's interactive dashboard.
Thank you, Diana. And just give me a second here to share myself. Yeah, so here we're showing the dashboard of Massachusetts health system performance. And the dashboard, as we've done every year, highlights a range of metrics with both a Massachusetts comparison, Massachusetts in the current period versus the previous, and the US to Massachusetts comparison. This year, we've hoped to have done a little bit of a redesign to improve performance, navigation, and usability. You can see here, this is the main table that shows all of the measures in the dashboard, like you'd see in the print version. And here we have a just at a glance view of those performance metrics. And if you hover over, you can see more detail, the similar style of hovers that Diana showed. And you can see here that we have both the Massachusetts and the US comparison. And we've also added a way to filter to the different key areas that are within the tables as well. If we go to benchmark and spending, we'll only see those measures. Efficient high quality care delivery, we'll only see those measures, and so on through APMs, alternative payment methods. This year, we also wanted to further highlight health equity and affordability, a section that we expanded last year. And if you open that, you'll actually get not only a filtered version of the main table to just those health equity and affordability measures, but you'll also get a breakdown of disparities by race, ethnicity, and by income for certain measures. So if we go by race, ethnicity, we'll see a slightly different view. And here we have infant mortality per 1,000 live births, and premature deaths from treatable causes per 100,000 persons. And we can see that there is a ranking of disparity by race ethnicity here, from the best performance on the measure to the lowest performance on the measure. And we also have a hover here that allow us to get a further detail, including on the sources. By income, it's the same, but it's a different comparison. Here we are comparing those with high incomes versus those with low incomes. And we have measures for out-of-pocket spending, those who went without care because of cost, an affordability concern, and adults without age-appropriate screenings, and those with fair or poor health. And you can see the print version of the dashboard as well at the end of the cost trends report, and obviously using the functionality that Diana just displayed. So thank you. I'm happy to show this to you guys today.
Great. Thank you, Leiden. Thank you, Diana. Great presentation and great work putting this interactive work, as you said, for greater data exploration for the public and for our audiences. Let me know when we're back on that. So shifting gears now, wanted to begin the conversation on the policy recommendations and where we landed this year. First, I just want to say thank you to all of the commissioners in particular for all of your insights and suggestions and comments and edits as we developed these recommendations this year, both throughout the summer and as we were sharing drafts in recent weeks. Your comments really helped inform the structure and format for these year's proposed recommendations. Similar to the last 2 years, we've really tried to anchor these recommendations around 3 key themes that we do believe are interconnected and interrelated challenges facing our Massachusetts healthcare system. The issue of cost containment, affordability, and equity. And we see these challenges as interconnected, as I said, and contributing to each other. And unfortunately, what we see from a lot of the data in our report is that this cycle is moving in the wrong direction. We see increasingly that it's more unaffordable, that cost growth is higher, in our healthcare system that spending growth exceeded the benchmark on average over the 2-year period that we looked at. We see that prices continue to grow. And this is contributing to higher premiums and higher out-of-pocket costs, both for employers and for consumers. We continue to see increases of the number of Massachusetts residents who have high deductible health plans, and exposure of those high deductible health plans continue to increase. What we know from the data is that the more and more that those high deductible health plans increase, the more and more likely residents are not to get the care that they need due to the fear of cost of care. We have a number of different studies that have shown an increasing proportion of residents reporting that they are not getting the care they need, not being able to fill their prescriptions due to the cost of care. This can contribute to higher utilization of the emergency department, can lead to worse health outcomes, and ultimately lead to premature loss of years of life. These affordability challenges, we know, are even more acute for BIPOC populations within our state and for low-income populations. And so these affordability challenges contribute to a deepening inequities in health and health outcomes. Our goal with these recommendations is to put forward a blueprint, to put forward a roadmap to change the trajectory of this cycle, to be able to focus on moderating healthcare cost containment growth, such that we're improving the affordability of care for the residents and businesses of the Commonwealth, and really being able to improve the equity of health access and health outcomes. So the recommendations that I'll walk through on the next slide, beginning on the next slide, begin with a recommendation that is slightly new this year, although contains elements that have been previously recommended. This first recommendation really is around an opportunity now, 11 years into this experiment, to take the lessons that we've learned and to be able to modernize and evolve our overall healthcare cost containment and policy framework. We believe, and we have made past recommendations on the opportunity to strengthen the healthcare cost growth benchmark, both by allowing for greater flexibility in the types of entities that can be reviewed and referred under the PIPS improvement plan, but also to change the way that that referral process works and to front load as we think about who and what entities are referred to the HPC for review, that we should not just be looking at a bright line test of whether their spending was above or below the benchmark, but that there are other important metrics that we should be front loading into our analysis about who should be subject to review and potential accountability. Metrics like, what is your commercial price level? What is the patient population mix? How much government payer patients do you serve? What is your size? What types of services do you provide? These are important factors when thinking about whether or not a performance improvement plan would be warranted. We have traditionally always looked at those factors in the confidential review process. But we think in this recommendation that there is an opportunity to put some of those metrics earlier into the process such that the market understands that there may be a differential referral, such that we're really focusing our attention on the entities that are most concerning to meeting our healthcare cost growth benchmark. In addition to that, we also have recommendations around strengthening the accountability in both financial penalties, as well as additional transparency of who is being referred on that PIPS performance list. Those are all things that we have recommended in the past, and we, I think, have tightened and strengthened some of the language specific around kind of a differential referral process. But this year, the new additions to this recommendation really are around complementing and bolstering our healthcare cost growth benchmark with two additional important metrics that we should be making targets for improvement, tracking our progress, and in fact, maybe having accountability on them as well. And so the two additional benchmarks that we're suggesting would complement and bolster the healthcare cost growth benchmark is new affordability metrics that would be more focused on the consumer experience of what they pay out of pocket, and that we're tracking our progress on these factors, as well as setting new targets and goals on health equity measures. The recommendations in our cost trends report do not specify exactly what those benchmarks or metrics would be, but call for a Commonwealth-wide process for developing and establishing them. Together, these three benchmarks will solidify that framework that we discussed before around driving not just moderation in cost growth, but ensuring that that translates into affordability for residents and employers, and that is working in concert with our health equity goals. The second recommendation is around constraining excessive provider pricing, which we know continues to be a primary driver of healthcare spending in Massachusetts and across the United States. In this report, we did a much deeper dive understanding the variability in provider pricing as compared to benchmarks such as Medicare, and have found that there were many places where provider pricing is far in excess of reasonable benchmarks. And we do think there are opportunities for public policy to limit those very high excessive pricing, as well as to limit price growth. The second sub-recommendation here is not a new one again for us, but is around what we just talked about earlier in terms of adopting site-neutral payment policies. And then finally, here again, a repeat recommendation from past years, but one that we've strengthened a little bit is around the opportunity for Massachusetts to adopt its state-only out-of-network default payment rate. Since the implementation of the federal No Surprises Act, we have been tracking and reporting back to this board regularly about many of the court cases that are challenging the implementation and regulation around that federal law. We issued a report in collaboration with the last administration on out-of-network payment rates, recommending that the state develop and require its own default payment rate. And we believe that the case for this is even stronger now that the federal process continues to be bogged down in challenges in the courts. We could make this much simpler for our providers, our health plans, and more importantly for consumers and businesses to be able to navigate if we were able to establish our own payment rate on out-of-network situations. So I have 9 recommendations to go through. So I'm going to stop on this slide because I do think number 1 here is an important one. It is one that is new and I think reflective of this board's continued emphasis on not just thinking about the benchmark, but thinking about affordability and equity. And I want to pause for a moment and see if there are any questions or reflections or comments about this concept of really modernizing and harmonizing our framework around these 3 concepts.
Great, thank you, David. Commissioner? Commissioner Castillo?
David, I have to tell you, thank you, that I love it. You know, since I saw how we did the last growth benchmark to add the affordability piece, and certainly for me, not for me, for everybody, the health equity piece is incredibly important. So I just want to say that I'm thrilled to see that. So thank you.
Thank you. Commissioner Boyd?
Yeah, I mean, just to add on to that and add my voice with, I think these recommendations are incredibly strong in the first category in particular. And I think, David, I heard you talk about like differential rate. Let's take a differential approach. It takes what we've done in our private deliberations and adds that to a public discourse. Because like we've all been saying, and I've said repeatedly, is not all spending the same in this market. I do think that the healthcare cost benchmark and looking at who is having the bigger impact on prices and spending, and we've heard from the community hospitals, that's also a health equity issue because we know that the community providers that are in those neighborhoods and in those cities and towns throughout the Commonwealth are the ones that are getting lower rates, and it's impacting them significantly And we need those rates to grow, those hospitals and those providers, where we need to limit in other areas. And so I think this gives us not just the commission, but the healthcare industry of Massachusetts and everyone invested in it, more information about who's impacting cost growth in the system, where we need to make more investments to address the health equity issues that we're seeing across the Commonwealth. And we also know that setting an affordability benchmark is also a health equity issue too, because the rising costs of healthcare are being clearly a bigger burden on lower income workers throughout the Commonwealth. So I think this is a really important addition to our policy recommendations, and one that I think gives us more tools to be more surgical in our approach about who's driving up costs and who's benefiting from that and who's not. And so I think this gives us a lot to work with, and appreciate the deliberations. And I think it's in response to what we've heard at all of our cost trends hearings, that we've had deliberations, but also when folks are testifying, we've heard the clear call for these types of changes to be more direct about who's impacting the cost growth and how those are impacting mostly the low-wage workers across the Commonwealth. So I appreciate this recommendation and the others to come.
So to echo a lot of the sentiments that have been expressed, I was also really happy to see two new types of benchmarks, affordability and health equity, primarily because these figures, these aggregate figures about overall spending growth in the system and cost growth in the system are relatively meaningless to individuals, families, even advocates, as they're trying to sort of interpret and understand this information. So I think, like others have said, this makes it sort of more interpretable, the cost growth data. And I really, at this point, I just mostly have a question about how these benchmarks will be calculated and set. So how will the affordability benchmark be determined? I'm not sure if that's something that we'll be able to dig deeper in the cost trends hearing, but I'd love to hear more about that.
Good point. Follow on in terms of how would we and when would we recommend going about developing this approach to the affordability and health equity benchmark. And we'll definitely take that up, not in this agenda item, but in soon. And I want to underscore, I completely agree with what my fellow commissioners have said about the importance of taking the cost growth benchmark and translating it into its effect on consumers, and both in terms of affordability and equity, understanding that over time. How is it changing and why?
David, I agree with the comments of my fellow commissioners. I'm glad to see the establishment, the recommendation to establish two new benchmarks. I want to put you on the spot a little bit, though. Here, a lot of these recommendations are the state should. Some we can't do because of our enabling legislation. Some require new legislation. Some we may be able to do outside of that. So as you go through these, if you could just identify sort of where the locus of responsibility is and where it's shared, so that the audience has a sense of what may be holding back implementation of some of these recommendations.
Absolutely happy to be put on the spot. Thank you, Commissioner, for those comments. And I should have stated at the beginning, these policy recommendations really do become a launching pad for our work and engagement for the next year. And I fully expect, Dr. McGregor, that the questions of how would we measure affordability, what are the right metrics, what does an accountability look like with an affordability benchmark? I think these are tough questions, and I look forward to engaging with the healthcare leaders and policymakers at the hearing to talk about this. On health equity, again, is that a single metric? It's hard for me to think what a single metric may be, but maybe that is a starting point. Maybe there's a number of metrics. I want to give an opportunity just to acknowledge Secretary Walsh and the Healy-Driscoll administration, who I know are putting a tremendous amount of time and energy and thought into thinking about health equity targets and goals. And so on that one, I do think that is really truly a Commonwealth-wide conversation of what those may be and how all of us as state agencies and the market can work together to achieve that. But I do think in both of these cases, there is work that we can do ourselves as HPC and in coordination and collaboration with the other state agencies to move these ideas forward. We have already been talking with the Center for Health Information Analysis about what information they collect on affordability metrics. Do they actually need more data authority in their statute, or do we have the existing authority to be able to measure some of these important things? So I think with many of these, and Commissioner Cohen, I will do my best, with many of these, could they be absolutely strengthened if put into law and supported by the legislature? Absolutely. Some of them require that type of statutory change. But there are others where I do believe we can continue to push this ball forward and move these agenda items forward, and really look forward to working with you on that.
Great, thanks for that clarification.
So I'm going to continue just moving through these. I'll probably try to do a little bit quicker and maybe spend a little bit more time on some of the newer areas. Again, I will give the disclaimer here. These are in no particular order, except for number 1, which I do feel like is really got an umbrella recommendation over all of these. The numbering here is often an artifact of history and not wanting to change numbering from last year, such that would look like we were de-emphasizing certain things. So all of these are important. All of these work in concert together. So the third recommendation is around, is one that we have done before, around enhancing oversight of pharmaceutical spending. Pharmaceutical spending continues to be a major, an increasing area of the healthcare dollar. It is an increasing slice of the pie. This was one of the categories of service that did not have a negative spending trend in 2020 and has had multiple years of high over benchmark growth. And our state law does not put the same types of requirements in terms of transparency and accountability on this sector as it does to all of the health plans and to all of the healthcare providers. So we believe, again, in the interest of fairness and that all parts of the healthcare sector need to be working together to meet these goals, that the pharmaceutical sector should be more firmly embedded within the healthcare cost containment policy framework. That includes both transparency and data collection. It includes not just the pharmaceutical manufacturers, but of course the pharmacy benefit managers, who also play an increasingly important role. And we do think that there are other state policies that we can build on, such as the HPC's review of process that we conduct with Mass Health that we could explore expanding. The fourth recommendation is also a bit of a repeat from last year, and ensuring that health plans continue to be held accountable as we are hopefully driving moderations in spending growth through some of our other policies here, that those, as I think you said, Commissioner Foley, those savings are then actually passed through onto the consumers and the ratepayers and the small businesses of the Commonwealth. We think that there is opportunities to enhance the scrutiny in the annual rate review process. I would acknowledge DOI has made some improvements to that review process, but that continues to be an important process by which additional resources could be dedicated. We spent a great deal of time in the report on looking at the small business market and the really shrinking enrollment in that market, which is driving a lot of small businesses and small business employees to really face unaffordable costs. There is a place, though, where many of those small businesses and employees can go and get healthcare at a very competitive price. And that's through the Connectors business platform. So we do think that there is an opportunity to continue to promote businesses working through the connector, where we have in Massachusetts some of the most affordable health plans in the country on the exchange. This is a jewel we should continue to promote enrollment into the connector plans. We do think there are opportunities to mitigate some of the impacts on high deductible health plans through premium support, and then finally a continued recommendation around continuing value-based and alternative-based methods. On the next slide, building out our recommendation around health equity. We have here our kind of a dedicated health equity recommendation, but as has been noted before, really the health equity components of this flow throughout many of these recommendations. Here you can see some of the sub-recommendations, which I won't speak through in total detail, but understanding that what drives many health inequities are factors that exist outside of the healthcare system, so we need to broaden the scope of our policies and strategies. The need for better data collection and that can help support targeted investments. And we did a specific recommendation this year based on much of the work that is so top of mind to the administration, to our new Attorney General, and to our newest commissioner around reducing inequities in maternal health in particular. Our sixth recommendation is around reducing administrative complexity. This has been a topic that we have discussed at multiple board meetings throughout the year. We do see this as an opportunity that will have benefits throughout the healthcare system, both on health plans, on healthcare providers and clinicians who are often faced with increasingly complex administrative requirements. This contributes to clinician burnout, and it also is extremely complicated for patients trying to navigate the system. How can we put in place some reasonable policies that would improve and reduce the unnecessary administrative complexity and drive value for this system? We think there are some opportunities in greater standardization of some of these payer and provider processes. Here, a new recommendation around requiring the automation of prior authorization. And finally, more alignment on quality measure reporting using the state's aligned quality measure set. I'm just going to keep going to the end, and then we can come back on any one of these. Number 7 on the next page is around strengthening tools to monitor our provider market. This is a slightly new recommendation, I think reflective of much of the work we've done examining both the increasing closure of certain types of services across the Commonwealth, in other cases proposed expansions of different types of services, and a need for the state to update its process for understanding the supply and distribution of healthcare resources and how well that supply and distribution align with the actual community need. And so we do think that there is an opportunity for perhaps the HPC in concert with others to do more focused assessments of need, supply, and distribution of healthcare resources across the Commonwealth. I think the recent pediatric report that we released is a good example of an examination where we looked at a specific service line and we're able to understand how is the service line changing, how is it impacting patients' access to this care, and in a rapidly dynamic and changing healthcare market, what is the role of government in ensuring that these market dynamics are actually going to be delivering value to residents and to patients? And so we think more assessments of need, supply, other times called health planning, although we try to make this a little bit more of focused assessments on certain either geographic areas or service lines. And then that would then flow through to improvements in our determination of need process, our essential services closure process, as well as the HPC's own review of material changes and cost and market impact review process. The last sub-recommendation of note here is a call for a change to ensure that material provider changes that have a significant private equity investment component to it should be referred to the HPC, should be noticed to the HPC for review, just as other significant provider transactions are today. That will require an update to that specific language in the statute. But seeing the increasing role of private investment and for-profit investment in healthcare, we want to make sure that our regulatory tools and oversight tools are evolving with this rapidly evolving market. Number 8 is an important new recommendation on supporting and investing in the healthcare workforce. Again, as I talk to leadership across the Commonwealth, this continues to be the number one thing that providers talk to me about, and the concerns around being able to rebuild and sustain and strengthen their healthcare workforce. We had an incredible event earlier this year and released our own report that had a number of recommendations around strengthening the healthcare workforce. We've imported many of those recommendations from that report into this report so that it is a part of our agenda moving forward as part of the annual cost trend report. And then finally, number 9, one of our favorites, is the need to continue to strengthen high-value services. And here we're very specifically talking about primary and behavioral healthcare. We know that high-performing healthcare systems spend more of their money on primary care and behavioral healthcare. And while the state has made some progress with CHIA and being able to measure the proportion of the healthcare dollar that goes to primary care and behavioral healthcare, that data also indicates to us that the proportion is staggeringly low. The proportion of spending that goes to primary care, I think, is less than 10% of the total healthcare dollar. So this recommendation is really around how do we continue to invest in, and as Commissioner Floyd said, not all spending is the same. And this is an area where even as a cost containment agency, we are recommending that we should be pursuing policies to increase investment in these areas. And also increasing access to behavioral healthcare services and thinking about using different parts of our healthcare workforce to be able to support that, like peer recovery coaches, community health workers, social workers, etc. So there is so much detail under each one of these recommendations. Commissioners, you have all seen the full written text, but I wanted to just give an overview for you and for the public around these 9 recommendations. I will stop here. I'm happy to kind of talk through any one in particular, but also just to get feedback from commissioners about what you all think of this slate as of recommendations for this 10th annual report.
Thank you, Executive Director Stouts. Let me open it up for comments, questions. Right. Commissioner Castillo?
I just want to say thank you. David, you did it again, and you have made me a very happy person today just to see what you have put in here. And the last one, the 9th one, behavioral health and the opioid use, I am thrilled. So thank you.
Great. Commissioner Cutler?
So I'm also delighted to see all these. I have a little bit of a slightly different question, which is we've had mixed success with our recommendations in the past. Some are really recommendations to us, but others are recommendations to others. So I guess I just want to get a little bit of your reflection, David, on what makes our recommendations be more successful and when are they less successful, and sort of what can we do more of to help ensure that these get taken care of or they get addressed somehow?
I would first start by saying I think the legislature has made tremendous progress on a number of these areas over the years. There have been comprehensive proposals that have advanced both branches in recent years. There have been comprehensive proposals from the previous governor. And while some things have certainly gotten across the finish line, I think, unfortunately, in some years that hasn't been the case. I am a perpetual optimist, and I've heard both the Speaker Mariano and Senate President Spilka talk about the priority of healthcare reform this legislative session. Both Chair Vaughn and Chair Friedman have been working very hard on putting more legislative language around a lot of these recommendations. I do think that this is, an important document for us to be able to work with our legislative partners and our administration partners to be able to help advance those areas where we really do need the statute to evolve and to change. And here, as we have now, 10, 11 years of experience, to me, this feels like the perfect opportunity to create a new framework and pathway for the future. That all being said, the dynamics, we can only control what we can control. And I think that is important to what Commissioner Cohen said earlier, which is of many of these, we can and should continue to dive deeper into the data, into the research, creating policy proposals that we can give both to the legislature, but also other areas where we can work directly with the market. There may be areas where we don't need to have legislative change in order to have an impact. I think, Commissioner Cutler, to your suggestion, I think to Commissioner Cohen's suggestion as well, as we think about our work plan for next year, maybe we take these recommendations and we kind of, for each one of them, have a sense of what are the things that we can do at the HPC or in partnership with our state agency partners to kind of move these forward, recognizing that some will require that legislative change, and use that as a basis for our work plan for 2024.
Thank you for raising that. I think it is going to be very helpful as we reflect back on this past year and plan for next year to look at those two categories on each of our goals. What can we do without any expanded legislation, and what would require further action? Commissioner Fuller?
Yeah, I think that's a really great idea, and it starts to answer some of the questions about how do we get some of these things done? Where's the progress made already? I'm just looking at the workforce piece in particular. I know the state legislature with the governors put investments in workforce development programs with the college. So there are things that are in motion, clearly haven't solved the workforce crisis within healthcare and other sectors. But I think there are examples of where we're making a lot of progress. One shameless plug is we just settled a very good contract for our home care workers, 58,000 Medicaid funded workers. Thank you, Secretary Walsh and the governor for that. But it speaks to the need to make investments in the direct home care workforce. So I do think there are areas that's been real improvement to address some of the critical issues around the healthcare workforce. And to your point earlier about this is what you hear everywhere you go, it's what we hear everywhere we go as well. And talking to the healthcare workers at 1199, it's not gotten any better. It's just getting worse. Folks are very tired, burnt out. They've been through a lot. They're being asked to do a lot more than they have in the past. And I think these recommendations that are outlined are both incumbent upon the state policymakers to address, but also to your point, the industry itself. There are things that industry needs to be doing, as well as some of the state policy work that we continue to do. I would just want to also add, I think under the enhanced HPC's Market Oversight Authority of for-profit investment, I just think that's a really critical recommendation that we're making this year. I think it might be good at some point to understand how much growth there has been in the for-profit markets in Massachusetts. And I think at a minimum, it's the oversight of their market changes and impact, but also their financial models and the potential impact of failure if one of those systems was to fail. What are we doing as a state to address the real healthcare needs for many of the communities that the for-profits are currently in or entering into? And so I think knowing where it's growing, who is coming into the market, and their underlying financial structure, I think is really important for us as a state and as a commission to understand, because it's growing and it's a growing concern that I know that I have and others share as well. So thanks for that recommendation.
Commissioner Cohen?
If I could just pick up on Commissioner Foley's point about the for-profit investment, I'm glad to see that added. I actually thought last year's recommendation was the best set. This exceeds that, and partly because we've added that. And I raised this to pick up on Tim's point. I read a Standard & Poor's market analysis report this morning. The bankruptcies of private equity investments are up 13%, the highest they've been in 13 years. And the number one sector where those bankruptcies are occurring are in healthcare. So it really is incumbent upon us as we think about the mergers and acquisitions to really understand what that impact is going to be on the Commonwealth. And just want to plug the recommendations for behavioral health as always, and thank you for including them in this year's report.
Other observations or comments? Dr. Castillo, did you have a?
Yes, I just wanted to add that in the last proposed talking about mental health and the opioid piece, I want to just add that we to consider also taking into account homelessness, which sometimes may go hand in hand. Huge problem for the community, huge problem for hospitals, and what kinds of things can we put in place overall for the state to look at.
Great, terrific discussion. Any last comments? Executive Director, Commissioner Foley?
Sorry, it's a very specific question. Maybe I should know the answer. But on the recommendation 5, it says data standards recommended by the Health Equity Data Standards Technical Advisory Group. Who is that?
That is a technical advisory group of the Quality Measurement Alignment Task Force, which is a group that is led by the Executive Office of Health and Human Services, but has been supported by HPC and CHIA. They convened a group specifically to kind of think about data standards in this area and have put forward some proposals.
Good. Any other comments, questions, or Executive Director Sells, any thoughts before we turn to the vote?
Well, I just want to say thank you to the commissioners for your comments, and this really is a reflection of the organization's values and principles, and so many of your suggestions are reflected here. Just a couple of notes. This really will drive our work moving forward. On the private equity piece in particular, Commissioner Foley, I do want to just preview that we have been spending some time doing that exact work in terms of trying to track and understand the private equity in healthcare in particular, obviously, in Massachusetts, as well as really getting a little bit smarter nationally in some of this research about what are the implications of this. Other states are increasingly looking at this. California, as part of their kind of oversight structure, has some interesting regulations around private equity, but this is, all states are facing this. All states are really concerned, and I think this is a place where Massachusetts could truly be a national leader in thinking about how we examine and understand these types of new market entrants and transactions in order to be able to be more proactive rather than reactive when something negative happens. And when something negative happens in a bankruptcy or closure, that often may lead to real negative impacts on access and quality. And so how do we get ahead of that and think about that? So that's really the spirit of that recommendation. I will stop there. A lot more work to be done on these, but I'll turn it back over to you, Chair.
Thanks so much. And before we turn to the vote, I just want to say on behalf of all of the commissioners how much we want to congratulate the staff, both for the continued evolution of the type and depth and breadth of data that is available as a resource to the Commonwealth, which is, as Commissioner Cohen said, it's getting better every year, but also the ease of use and the navigation tools, which I think are a tremendous breakthrough, and we'll look forward to hearing more feedback from that from those who use it. So with that, let me ask that we turn to a roll call to vote on whether to approve the report for release today. And I'll ask Lois Johnson to take us through that.
Chair Bo, and I hope everybody can hear me this time. We have on the slide the motion, but do we have a motion to issue the report?
So moved.
And do we have a second?
Second.
And any further comment or discussion before we go to the vote? Hearing none, I'm going to start with Chair DeVoe. Approved. Vice Chair Cohen.
Approved.
Commissioner Blakeney.
Aye.
Commissioner Castillo.
Approved.
Commissioner Cutler.
Approve.
Commissioner Foley.
Approved.
Commissioner Haupt.
Approved.
Commissioner Master Giovanni.
Approved.
Commissioner McGregor.
Approved.
Commissioner Kwasnick.
Approved.
And Commissioner Walsh.
Approve.
Thank you all so much. As always, a big moment for us, and we'll look forward to releasing the report. Our next agenda item is to talk specifically about how the HPC is using the health equity lens in our work. And I'll turn it over to David to introduce our speakers and discussion.
Thank you, Chair DeVoe, and thank you, Commissioners, for that unanimous vote. We are very excited to be able to release the report and for the public to be able to see the great work and recommendations. For the next agenda item for today's meeting, we are actually returning to an agenda item that we had scheduled for the July board meeting, but we ran out of time and felt like it was an important enough conversation to bring back to this agenda with a little bit more time left on our meeting schedule. This is really our annual report out to the board about our activities on health equity, for you to hear about how we continue to embed health equity in the work of the agency, for you all to give us continued feedback and guidance as we continue this journey, as well as an opportunity for us to be held accountable that we're continuously updating you on this work. So in 2020, we actually changed our mission statement to make an explicit commitment to addressing healthcare disparities, advancing health equity, and promoting social and economic justice through our work. Our mission statement was changed a little bit to reflect that, but this is also part of our statute. Our underlying statute actually calls for the HPC to set goals around reducing disparities, and so we do think that this is very much a part of our work as an organization. We have, since that time, really been intentional about how we build health equity into the work of the organization. I'm going to give a little bit of a brief overview, and then what you're going to hear from is members of the leaders of the different teams, the policy teams of the HPC, will give their own presentation about the work on those different departments on this topic. So since last summer, when we last gave an update on this, we've done a lot more work in really trying to put equity and disparities into our research work and into our internal processes. The core of this is really an equity in everything concept, which is to put it into all of our work streams, all of our research projects, all of our investment programs, to have a very intentional way of thinking about how our work can contribute to this broader goal in everything that we're doing, from the initial kind of contemplation of a research idea, the initial contemplation of an investment program. We have really worked hard to and continue to seek opportunities to collaborate with other state agencies and other organizations. I already mentioned the incredible leadership of Secretary Walsh, the Healy Driscoll administration, Dr. Kiame Mahanya, who is the Undersecretary of Health, and Karen Sung have all been working really hard in thinking about how, as an overall government that has and touches so many people in health and human services, how we can coordinate and work together. And we are so thrilled to be a part of those conversations. But in addition, we also know in the last year, there's been the real kind of launch of the Health Equity Compact, which is an incredible group of BIPOC leaders from across the healthcare system that have really made health equity one of their primary goals. And we've tried to sought opportunities to align and work with them and with other organizations. Through our Office of Patient Protection, this is really our consumer-facing office where we are fielding requests for assistance from the residents of the Commonwealth around medical necessity denials. and other insurance denials. And we do, as part of that, really try to track and make sure that we're identifying any negative trends in terms of denials or disparities between different patient populations as we look at kind of how patients are navigating that part of the healthcare system. We have internally embedded a lot of intentional work around professional development and learning and listening and having opportunities for staff to engage with each other, but also with outside experts that we've brought in on different topics. And finally, annually, and we've been updating what we call the Health Equity Practice and Style Guide, which is a guide that we internally developed really on a grassroots level from the staff here around the terminology and the use of words and making sure that we're being very consistent in our use of language across all of our reports. That style guide has been updated multiple times and is available on our website. So that is a pretty broad overview, but I want to give you all a sense to see how that all plays out in action. And so we're going to hear from 3 different staff members now. We're going to start with Catherine Harrison, who's our Deputy Director on the Healthcare Transformation and Innovation team, who's going to talk a little bit about how we think about equity in our ACO programs. We're then going to hear from Dr. Sasha Albert, who's an Associate Director on our Research and Cost Trends team, about how we've thought about this in the course of our research and cost trends work. And then finally, we'll hear from Peter Vidal, who is Director on our Market and Oversight team, who's going to be presenting for the first time to you commissioners a little bit about some research work we have been working on for quite some time that is going to be focusing on cataloging and understanding healthcare disparities in the Commonwealth and the relationship between those disparities and the supply of resources in the Commonwealth, as well as other financial and non-financial barriers that may contribute to healthcare disparities. So that last one is a bigger topic that I will say right now will be a main focus for a lot of conversations moving forward. But to have this health equity conversation, I didn't want to lose the opportunity to share a little bit of the work that we've been doing. But let's start with Catherine Harrison on the HPC team.
Wonderful. Good afternoon, Commissioners. Really nice to be here with you, and a special welcome to you, Dr. McGregor. Really looking forward to your contributions and to working with you. So as David described, I am going to talk a little bit about the approach that we've taken to applying this mission that the Health Policy Commission has taken on to embed a health equity approach in everything we do, with particular regard to our healthcare transformation and innovation work. And as David mentioned, this does include our ACO certification and our certification programs generally, but also in this portfolio is our investment program work, which you'll be familiar with. And there is a lot of other stuff that falls into this bucket, into this portfolio, that we don't usually have as much opportunity to share with you. You'll hear me refer to some of it today, but it's a variety of activities that relate to advancing improvements in healthcare delivery. A lot of it is done in collaboration with other state agencies or organizations. So just to ground everybody kind of in what is the portfolio of work we're talking about here. With that said, there are kind of 2 things I want to do in my brief presentation today. One is sort of share with you the overall approach that we've taken, and it kind of falls into these 3 categories on this slide that I will go through. The second thing, that I'm sort of trying to, I think, illustrate as we walk through this presentation is that we are, I think, navigating and attempting to find an important balance between 2 ideas. And the first idea is, let's not let the perfect be the enemy of the good. When it comes to working in the health equity space, we need to move. And, we may not have perfect information. We may not have all the expertise we want. We may not have perfect data, but the importance of taking steps, doing something, trying something, recognizing we may fall flat or fall short of our goals, but keeping going. So balancing that on the one hand, and on the other hand, the idea that, issues of health equity are too important to do in a casual way or to do without the same kind of attention and rigor and commitment to excellence that we do anything we do here at the HPC. So as we sort of attempt to hold these two ideas in our hands, which are a little bit in tension with one another, I think you'll see that reflected in some of the advances that we've made, some of the challenges that we continue to have. And I would say it's an area where we're really looking for your thoughts, your feedback, your guidance and support as we continue to try to strike that right balance. So with that as a little bit of background, let me first start off by sharing sort of the overall approach that we've taken to focusing on health equity in the healthcare transformation and innovation portfolio. So the first is pretty straightforward and obvious here. It's embedding health equity in the content of our work. So whether that's primarily focusing an investment program with a specific equity intention, or maybe there's a program where the primary focus may not be equity, but what are the opportunities still within that to think about equity issues, to advance health equity concepts in some way in that program. And as David has said, just as the agency has made a commitment to thinking about equity in everything we do, we too have been trying to advance equity in some way in each of our work streams. So that's the content piece. On process, this is really about taking a look internally at the methods that we use and the approaches we take to doing our work. And this speaks to, are the inputs that we're putting forward, are the structures and processes that we use, are they aligned with the outcomes that we want to see related to equity? If so, great. If not, what can we tweak? What can we change about the approach that we take to doing our work that might be in better congruence with our equity goals? And I'll give a few examples that hopefully will help bring that into focus a little bit more. And third, we've designed some mechanisms to hold ourselves accountable to the agency's mission, naming it as a work stream. So we really think about health equity implementation as its own dedicated work stream with staff resources and time allocated. Of course, it's an endeavor across all the staff who work on these projects, but we have felt that giving it some intentional focus is important. And we've also established a set of regular check-ins and sort of opportunities to discuss and collaborate and talk to each other about where we're making progress and where we're having challenges as an additional accountability mechanism. Okay, so on the next slide, to start with content, and this is a bit of a flyover kind of presentation, so without time to go into detail on each of these things, I hope I'll give you enough to sort of give a flavor. So the first example here is relates to our ACO certification program. So for the first time in 2021, we instituted a health equity response requirement into our standards for ACO certification. So that meant that as ACOs applied to us, part of the application involved giving us an indication of how they are advancing health equity in their organizations. In that case, it was around giving us an example of one specific initiative or intervention that they had undertaken based on an equity that they had identified. We learned a lot from that first certification cycle about the various efforts that ACOs have underway to address specific health inequities. And we had the opportunity to sort of call from that experience and communicate back to ACOs some opportunities that we saw for continued advancement. And these fell into the broad categories of improving data collection and use, engaging patients in the design of equity-focused interventions, and also taking a more strategic approach overall across their organizations to their health equity work. Based on those observations, we issued an updated set of ACO certification requirements for the cycle that is active right now. We call it the 2024-2025 ACO certification cycle, but applications are actually coming in this fall. So we have rolled this out, and we will soon be receiving applications that address the new requirement that focuses on those three areas of opportunity. And our standard now asks ACOs to report to us on their progress on these three specific categories. The idea being we are, trying to maintain a focus on these three areas over time and chart ACOs continued improvement. Certification happens every couple of years, so we'll have the opportunity, hopefully, to track and chart progress over time in what ACOs are doing to improve their data collection, to engage patients in the design of equity-focused interventions, and take a more strategic approach overall. Secondly, on this slide, you'll see reference actually to something that just came up. The HPC does support the work of the Quality Measure Alignment Task Force, which is spearheaded by the Executive Office of Health and Human Services. This group has taken a number of steps forward this year with regard to quality measurement. And as described, I think, as you know, in addition to curating an aligned measure set, over the past year, the task force developed, disseminated, and is now working to help providers implement standards for collecting data on patients' race, ethnicity, language, disability status, sexual orientation, gender identity, and sex. The QMAT also adopted recommendations for equity-focused measures for the aligned measure set made by the dedicated health equity measurement work group. So this, I think, group overall reflects really exciting progress that the Commonwealth is making toward this critical goal of collecting better information to help us understand and address inequities in the Commonwealth. And we are really happy to be supportive of and continue to participate in that group. Third thing I want to sort of unpack a little bit for you is relates to the issues around maternal health equity. And this is an area where I think both as a care delivery sort of team, but across the HPC, we are deepening a focus here on maternal health issues, and I think beginning to build a little bit of expertise in this area, which is really exciting and important. There are several projects that we have ongoing in this space. One is that we play an active role through participation in the DPH-led Maternal Health Task Force, which is coordinating recommendations or coordinating action against the recommendations made by the Commission on Racial Inequities in Maternal Health. My colleague Jasmine Bland sits in that space and is an active contributor and participant there. So that's a great platform. We also have 2 investment programs right now in this space. One is focused on supporting Black working people through the provision of doula services. So this is increasing access to a population for whom doula services may have, great effects. And the other program that we have ongoing right now is focused on improving access to evidence-based treatment for addiction and supporting caregivers and substance-exposed newborns with sort of coordinated care models that integrate physical, mental health, and social needs services. 2 really fantastic programs. One with a really sort of intentional, explicit, and with equity really as the primary goal, and another program where, whereas I think we are, the C% program is a little bit more holistically focused on improving care for folks with substance use disorder. We have an intentional focus in that program in supporting care models that address the very common issues of stigma and bias faced by those populations, which represents an inequity in and of itself. So that's a bit about our maternal health portfolio. And finally, I want to mention we are, developing increased focus in our evaluation work on issues of equity, particularly in our patient experience work. And this is really reflective, or this opportunity has come about, I think, particularly through our Beside investment program, which is the one I just mentioned, supporting Black working people with doula services. We are working with a contractor that is really expert and very focused on issues of equity and evaluation. So we've taken a number of steps forward. In addition to collecting patient demographic data from the awardees of the program, we are also implementing a patient experience committee that is made up of the patients and doulas who are participating in the program, who have been involved in helping design the evaluation, in addition to giving their input and their experience and their data to the program. Patient experience interviews are being conducted by Black interviewers for racial concordance. And we're also collecting doula experience data through interviews and written accounts in recognition of doula's expertise and to avoid only centering the experience of doctors and other clinicians in this work. All right, so moving on now to process. Let me just address a couple of things that we've been doing here. One is that, and I hope again that this sort of helps to make concrete what I was mentioning earlier about thinking about our internal structures and the way that we do our work. One of the most important things that we do in designing and implementing and evaluating programs is trying to hear from stakeholders. This happens, because out of necessity, we need guidance and expertise, and because we think it's really important to be designing programs that are relevant to the people and the institutions that they're directed at. One of the things that we have discovered over the past couple of years is that we probably need to expand the range of stakeholders that we're engaging and think a little bit more about how do we get into contact with people and organizations and perspectives and ideas that have sometimes not been included in our consideration in the past. And this is, I think, particularly true, that we know that if we want our work ultimately to have the goal of reducing inequities, that we need to hear from some of those perspectives that haven't been well represented in the conversations. So we've taken an inventory of who do we usually talk to, and we're really trying to think about how do we expand whose perspectives are perhaps being left out of that conversation. How do we begin to build new relationships, build connections, consume media and materials of all kinds that will ensure that we are kind of seeing the big picture and seeing all of the different perspectives and viewpoints on issues as we go forward in both choosing what to work on and thinking about how we specifically design programs. Relatedly, we are taking advantage of as many professional development and learning opportunities as we can. So we've had a lot of staff attending conferences, sharing and discussing the literature, availing ourselves of all sorts of external resources. And we try to take a systematic approach to making sure that if staff go to conferences or read something interesting, they come back and share so that the whole group benefits from their learning. And finally, on the topic of accountability, one of the things that we've done for this calendar year, 2023, is to have each of our work streams identify one specific health equity related goal for that project that they will do in that year. And this is a broad range of things. It could be anything from trying to embed a particular equity topic into an output that comes out of one of our investment programs for learning dissemination, or doing an after action review for our investment programs to think about where did we miss some opportunities to embed an equity approach. We have a quarterly meeting series that we have stood up where we come together and talk about all of these efforts, and that serves as an additional way of sort of that dialogue and holding each other accountable that we think is so important. So that's a good segue into the next slide, which is meant to look forward a little bit. In addition to continually and actively working toward those work stream specific goals that I just mentioned for 2023. Between now and the next time we might come back and update you on our health equity work next summer, we see some specific opportunities that I wanted to mention. One is we would really like to deepen our work with ACOs and figure out additional ways that we can support them to advance health equity, really honing in on some specific things that we could do perhaps in those three areas that I mentioned that our certification standards wrap around. And this could be something in the form of technical assistance or a shared learning opportunity or something like that. And I think we'll know more what shape that might take or have some new ideas once we see the applications that we're getting in the next couple of weeks and have a chance to review them comprehensively. Obviously, we want to align with where it seems like ACOs could use the most support. But that's an area that we're really interested in continuing to advance. And secondly, we have the opportunity pretty soon to start thinking about designing some new investment programs. All three of our current investment programs will be winding down as we get into the early part of 2024. The long tail will still have evaluation work to do, but we want to hit the ground running with some new programs and new ideas, and that opens a lot of doors to be thinking about what could we be investing in, how could we be using some of the dollars that we have through our trust funds to continue to advance health equity work. So that will be another kind of continued focus for us in the coming year. All right, so my last slide, and then of course I'm happy to take questions and also let my other colleagues share their perspectives with you. But I did want to close with a word about some of the challenges we faced. I think it's important to be honest and transparent about not just the areas where we've been able to make some progress, but some of the places that we continue to see as challenges. So I'll start by saying, I think as we identify more and more opportunities to use our certification and investment program levers to encourage our certified awardees, or our certified provider organizations and our awardee healthcare providers to advance their work on health equity, we are still working to try to identify resources that we can avail ourselves of to support them. So, expert individuals, organizations, data, practical tools, curricula, we're on the hunt for, resources that we can share. And more, there's a lot of stuff out there, which is both a blessing and a curse. We want to be identifying the best and most evidence-based models for improving care and decreasing inequities. So we're weeding through a lot of information, trying to find the right tools that we can bring to our Massachusetts community. And that continues to be a bit of a challenge. I think also, in line with that, this is in a good way, a crowded space increasingly, this work on health equity. And there's a tremendous opportunity, I think, for the HPC to figure out how are we best positioned to advance that? What are our particular capabilities, skills, opportunities, and how do we best align and complement the work that's happening elsewhere, whether that's in the state or nationally. So we're putting a lot of attention into sort of keeping current on all of the different initiatives out there from the state to the federal, and really trying to take a hard look at where can we lead, where can we partner, where can we sort of step back and let others move forward on certain things. And this is, just sort of a really, I really do see this as both a challenge and an opportunity, because I'm confident we do have a role to play, and it's a matter of figuring out exactly where in various circumstances. And finally, just to mention about our investment lever, this is such an important tool that we have. And this is a tough time to be in, this is a tough time for our healthcare systems, really, and the challenges that they have faced, from staffing and workforce issues to all manner of other challenges and requirements out there in the space. I would say has made it challenging for them to achieve some of the goals that they've set out in our investment program work. And it's also made it challenging for us in some ways to run investment programs really effectively. So this is just one that we continue to be mindful of as we look forward to designing new investment programs that may have enough equity focus. Again, it's sort of about where can we best contribute, where can we lean in, how can we use our dollars and our lever here to the best possible aim, knowing that this is a challenging moment for our healthcare system to be thinking about new things and staffing up for new endeavors. So that's not all the challenges, but that is where I will stop for now. And thank you so much for interest and support.
Thank you so much, Catherine Harrison, for that great overview of the work of HICD. And I think worth pausing for after each of the presentations for some questions and comments from commissioners. And I'll turn it over to you, Deb, to help steer us.
Sure, thank you. Great presentation. Commissioner Howell?
Just a clarification, I guess, on the Beside program. Can you hear me?
Yes.
Okay. Yeah, I was having a little trouble on this end. On the Beside program, which I know was really pretty wildly successful. And when we have an investment program and our investment ends, does the program end? What happens? I have a hard time seeing us put all this time and effort into rolling out something so wonderful and well received, and then either our investment ends or no one picks it up, or I want to understand the lifespan of these initiatives.
Yeah, that's a really important question. Something we think about a lot with our investment program work is that very question of sustainability, or continuing the program or the change once the investment ends. The honest answer is that it can vary from one program to another, or one awardee to another. How they sustain, to the degree to which they sustain the work that they've been able to do through the Health Policy Commission investment. I think in terms of Beside, one note is, the state overall is taking some steps forward in terms of trying to make doula services more accessible. I think you may know that the Mass Health Program is on a path to including doula services among its covered services. So I think that bodes well. And we are always trying to work with awardees throughout the duration of our investment programs on that very issue. And we try to the fullest extent we can to help them think about a model for continuing the work, continuing to offer the services. And I think in the particular case of Beside, one of our awardees has had a long-standing doula program for a long time, and the Beside investment has enabled some expansion and deepening of the particular equity focus of that program. In the case of another of our awardees, they have been so successful in enrolling patients in the program and working with the doulas in the community, that I think they have really shown a great ability to stand up the program, and I hope that bodes well for their continued success in terms of sustainability after the program ends.
Thank you.
Yes. Hi, thanks so much for that presentation and all the work you do. So I think my question is directed at the health equity technical advisory groups and the data standards. Are there any specific data points that you plan to collect, perhaps maybe with an eye toward better understanding how neighborhood or racial residential segregation and concentrated poverty impacts patients' ability to access care? I ask that because in the cost trends report, there was this particular finding that really struck me around commercially insured patients who reside in low-income zip codes being more likely to have zero spending on primary care, so zero spending on their behalf to access primary care. And that's a very worrisome finding for many reasons, but they're insured, so theoretically, there's some level of access that they have, but I think, we would all be better served to understand more about why they're not accessing primary care. Is it just a matter of lack of transportation? Is it a matter of lack of other types of resources, time, perhaps? Maybe they're working 2 or 3 jobs. This is, I think, particularly salient for Boston and for Massachusetts, where racial residential segregation is very entrenched, and there are some communities that have, no community health centers, for example. And then with respect to closure, some of our most vulnerable communities are experiencing closure as well. So just wondering if there were any thoughts around data collection to better understand neighborhood and racial residential segregation, sort of some of these broader structural questions.
and maybe Sasha can jump in here too. But so my understanding of the work of this task force of the quality measure task, the quality measure alignment task force, this particular working group on data standards, their focus has been helping set a common approach to collection of RELD and SOGIS data by healthcare providers on their patients. So what I'm thinking and hoping is that through the effort to collect better data that includes race and ethnicity, for example, that there would be a greater opportunity to marry that information with information we may already have about the patient's zip code or neighborhood that might further enable some of the inquiries that you're talking about around access and utilization of services. I think right now a barrier, we can, I think, look at some information by zip code and by sort of neighborhood, but marrying that with any information about race or disability status or ethnicity is not very possible given the data gaps.
Yeah, I mean, exactly as Catherine said, there are some things that we're most able to measure at the community level because of being able to use zip code as a linking variable to, for instance, variables from the census, a American Community Survey. But a real data limitation is patient or resident level data, and those are measuring slightly different things. That's something that the research team is always looking at. Commissioner Fuller?
Thank you. So just a few things. One, I really want to point out the stakeholder engagement piece. I think that's really important, the commission to be working on. I think it addresses and can be something to think about as when you're talking about some of the challenges, is how you can work with the stakeholder group to address some of those. Identifying experts, HPC role, like I heard them ask, like, what do people think the HPC role should be in this space, and how to use the investments more strategically to address the issues of health equity. So I think the stakeholder group, to me, or how you're thinking about stakeholder engagement, is really important in that, not most spaces, but this space in particular. And I think it could help some of the challenges. One question that I had, or two quick questions, is on the ACO certification process. I talked a lot about new standards around health equity. Will there be a public report to us about how they're meeting those standards or not on the ACOs? Is one question. And then one thing that jumped out at me within the stakeholder engagement piece was the notion of also how we do so. And I'm wondering, and I see language access as a health equity issue, and how are we as an HPC commission ensuring that these meetings and materials and everything that we do is available for folks that don't speak English as a first language?
Thank you. So starting with your question about ACOs, I think I'll basically say yes, we will come back and report to you on what we see in the ACO's certification applications about how they are meeting our standards, what the certification data tells us about the level of capacity at ACOs to address equity issues in these three areas. We are limited to some degree on what we can share publicly identified by ACO, but we will take every opportunity we can to be transparent about what we learn. I think for this topic in particular, there's a lot of good that can come from public discourse and transparency about it. So we'll look for those opportunities for sure and come back to you when we get those applications in and analyzed. With respect to the language access issues around process, it's an incredibly important question. I think for me, it raises sort of a macro question that we continue to think through. I think both within our care delivery transformation work and perhaps as an agency, which is, we are kind of somewhere in between being a really public-facing, consumer-facing group and being like a real wonky, like back, you get what I'm saying. So I think it's a really important question for us to continue to talk about. Where do we want to fall? In what cases do we want to see our materials become really accessible to the general public? How should we be tackling some of those issues? And I'm sure others in the agency, other than me, would have thoughts about this. But I appreciate your raising it because I think it comes up a lot, and it even comes up in the stakeholder conversations. You know, should we be trying to reach down into neighborhoods and populations and be attending meetings and saying, hey, we're the Health Policy Commission, you know, we're trying to improve healthcare, what do you think? What's our place in that, sort of on that spectrum? So I think it's a critical issue for us to continue to wrestle with.
Commissioner Blakeney?
Thank you. In order to build a little bit more on Tim's suggestion, I think we're all acutely aware of the emerging immigrant issue across the country, and especially here in Massachusetts. We're seeing our state struggle to find resources, and some of those resources have to be healthcare resources. And so as we think about where we go next, and as we think about what emerging issues and trends there might be, I think part of what I would encourage us to take a look at is, should we, and if we should, how do we get involved in thinking about innovative service delivery models to the emerging population, which is the immigrant population that is overtaxing and will continue to overtax the resources here in Massachusetts.
That's a great point. Thank you very much for that suggestion. Appreciate that.
Perfect presentation and discussion. Thank you. Let me pause for a moment and just do a lifetime chat with David Seltz. I'm wondering, the discussion I think has been incredibly important. I'm wondering whether we should carry over our other two speakers to the next meeting, or how you want to.
I think it has been incredible. Thank you, commissioners, for this conversation. Catherine, amazing job, as always. But I do think let's hear from Dr. Sasha Albert from the Research and Cost Trends team. And then I think, Kara, you'll be off the hot seat for today. As I kind of previewed earlier, Kara's presentation is around a pretty important upcoming research work that I think is worthy of much more time of commissioner engagement. And so I think worthwhile to hold that conversation, and I can close out the executive director's report quite quickly to keep us on time. But love to hear from you, Dr. Albert.
Thank you so much, and good afternoon, commissioners. I'm pleased to share a high level, especially in the interest of time, look at some of our recent and upcoming research work with an equity focus. But before I get into going through our various publications, I want to share a little bit about how the research team ensures that equity is part of our thinking and our planning and execution. So part of the challenges, as we were just discussing, is data. And we prioritize staying up to date on recent health equity research, publications, journalism, and data resources at our team meetings to make sure that we are learning about new ways to use the data resources we already have, learning about new data resources that we may not have used so far, and thinking about new ways to incorporate an equity lens into our work, and to think innovatively and creatively about how to ask research questions that prioritize health equity. And then, of course, we need to be able to interpret what we find in a way that is meaningful to the people who are closest to what we're studying. And so for many projects, especially our larger projects, we do a fair amount of stakeholder engagement with folks who are closer to the ground, closer to the issues that we're studying, to get perspectives on what we're seeing in the data, why it's there, what it means to the people who are experiencing the various areas of healthcare or cost and affordability implications that we're studying. On the analysis side, as a regular part of the studies we conduct, we build in steps to explore and understand disparities by factors such as race and ethnicity, age, income, and geography, which are at the moment, the elements that we're most equipped to look at the patient level.
I guess income being an exception there because that is usually by community level. But just to give an example, when looking at out-of-pocket costs for a health service, we can compare out-of-pocket costs for that service to the median community income in different areas of the Commonwealth to measure not only how much money people are spending on average, but the affordability implications of that spending for residents in different areas. For instance, we can say, the out-of-pocket costs for this service on average are about $1,000, but for our lowest income residents, that might be 3, 5, 10% of the median income in the neighborhoods where they live. And that really makes that finding a little bit more real and gives it some, the implications of that spending beyond just a dollar amount. And we're always thinking about new ways to use the data resources that we have to understand health equity, which I'll discuss more in a few minutes. And lastly, just as an internal team process, we track our ongoing projects by the degree to which they emphasize health equity, to make sure that we're always working on studies that do have an equity focus. So moving back to what we have on the slide, in the past year, just to give a highlight reel, we've had several publications, including 2 major legislatively mandated reports with a health equity focus. So last winter's report to the legislature on telehealth use in the Commonwealth included analyses of telehealth use by community income level and access to broadband. And last spring, we published a report to the legislature on the Massachusetts healthcare workforce, which included a focus on direct care providers, who are among the lowest paid healthcare workers in the Commonwealth. And we noted the inadequacy of direct care wages relative to the high cost of living here in Massachusetts. And as Director Seltz mentioned, we released this work at a special event on the healthcare workforce, which included a really rich conversation about healthcare workforce diversity and the relationship between the healthcare workforce and equitable outcomes for patients. We also published this past spring an issue of our Data Point series on persistent cost sharing for contraception in Massachusetts, which included a look at affordability. And in our 2023 cost trends report, we include an affordability section focused on residents working at small employers. We've also added a new primary care and behavioral health chart pack with a focus on primary care spending and mental health therapy visits by income level, as well as an exploration of behavioral health emergency department visits and hospitalizations by patient race and ethnicity. And as our colleague Leiden shared a little bit ago, our 2023 dashboard of health system metrics includes metrics on affordability, access, and health disparities by income and race and ethnicity. So on our next slide, I'd like to share a few examples of our ongoing work with a focus on health equity and some opportunities we're thinking about for enhanced data use to really strengthen this work. So we are currently working on a study on equity in birth outcomes, specifically exploring disparities in severe maternal morbidity diagnoses, looking at the spending and affordability implications of those disparities. We're following on the recent really robust and alarming DPH report finding substantial disparities by race and ethnicity in severe maternal morbidity. And we're interested in exploring whether the same groups who are experiencing disproportionate rates of adverse health outcomes are also bearing a disproportionate financial burden as a result of the additional care that they may need. And building on our conversation at last spring's healthcare workforce event, our next wave of focus on the Commonwealth's healthcare workforce will include an exploration of workforce diversity, including the value of diversity in the healthcare workforce and barriers to increasing it. So as I mentioned, we're always thinking about new ways to use data to understand health equity. And among the enhanced data use opportunities we're exploring are linking our claims data to our hospital and emergency department discharge data. And this is a little bit in the weeds, but our claims data, a major limitation of our claims data is that it does not have patient-level race and ethnicity information, but our hospital inpatient and emergency department discharge data does. And so if we're able to link them together, we can understand not only the utilization patterns of various areas of care by patient race and ethnicity, but also the spending and affordability implications of that care. And this is something that would be very exciting if we could make the data behave enough to do it. We're also interested in exploring methods for identifying individuals with disabilities. There's a fair amount of research literature on how to approach that in administrative data, and that's something that we're percolating on. And we're also interested in understanding more about whether and to what degree social determinants of health might be measured in the administrative data that we use. High level highlight reel here, but happy to take some questions before we move on.
Sasha, just a comment. When I saw the chart back on primary and behavioral health, I was pleasantly surprised to see as much race data expressed, and it left me wanting more. So continue.
Other comments or questions? Dr. Halper? Terrific. Yeah, I agree. It's going to be useful to also see, as we're able to get the additional data, what was masked prior to being able to see that. That is giving us a better picture. Thank you.
Thank you, Sasha. Thank you, Catherine and Kara. We will see you at a future meeting. And thank you, commissioners. It's just it's very exciting and energizing for me and for the staff of HPC to see your interest and engagement on this topic. So really do want to thank you. I'll just add one final point of reflection on behalf of Colleen Elsmeyer, who's not here, but as the Deputy Executive Director oversees many of the internal operations at the HPC. She has spent, and her team has spent, a lot of time thinking about how our internal processes can also support this health equity work, specifically around diversity, equity, and inclusion initiatives among our staff and the hiring of our staff, so that we have a staff that reflects the people that we serve as public servants. One of our strengths in that area has been our annual fellowship program, where we're able to bring in students every summer from across the country who may otherwise not be exposed to working for a government agency. And that has been a tremendous asset for us to be able to identify really qualified young people of many different backgrounds to come and work at the HPC. A lot more to be said on that front, but that is an important part of our work here as well. So we will close out in the last few minutes here with the Executive Director's report. We have our regular update on market changes and oversight. So I'm going to turn it right over to Sasha Hayes-Rusnoff to give us our update on recent material change notices.
Thank you, David. Good afternoon, commissioners. I'll keep this brief. Since we began reviewing material change notices in 2013, we've received 153 now. On the next slide, you'll see the 2 notices currently under review. There. First, the acquisition of the non-clinical assets of Greater Boston Urology, which is a Massachusetts urology practice with 7 locations, by U.S. Urology Partners, which is a private equity-backed management services organization that provides administrative and back office services to physician offices specializing in urology. The second transaction is the proposed acquisition of the outreach laboratory assets of Tufts Medicine by Laboratory Corporation of America Holdings, also known as LabCorp, which is a publicly traded multinational provider of lab services headquartered in North Carolina. LabCorp already has several outreach lab locations in Eastern and Central Mass. I'll also touch on, you might have seen that Tufts Medicine and Sturdy Health recently announced a clinical collaboration to support cardiology services at Sturdy. We've spoken to representatives of those systems about the details of what they're doing together, and we've confirmed that that collaboration is very limited, in fact, and doesn't meet our threshold as defined in our regulations and guidance for a strategically important material change. So it has not been noticed to us. And the systems are going to check back in again if they intend to expand that collaboration. And really, we encourage all entities to contact us if they're planning a new affiliation and aren't sure whether that affiliation will require a filing. And that is the update for this meeting.
Any questions from commissioners? Seeing none, the final few slides here just highlight some of our recently released reports and publications and some that are upcoming. On the next slide, I do want to highlight that we released last week the pediatric report that had been discussed at previous meetings. It is available on our website. Encourage you and members of the public to check it out if you haven't already. A really, really excellent report by the team, raising some really important questions around market dynamics in Massachusetts. We will be preparing for our annual cost trends hearing. The 2023 cost trends hearings is quickly approaching. Please save the date. Our registration is now open, but this is going to be an in-person event at our traditional location of Suffolk Law. So please start to register. We will have limited in-person capacity. And commissioners look forward to working with you on developing the themes and key questions that we want to discuss at the cost trends hearings in the coming weeks. So look forward to that. And next, on the final slide, we will be meeting next in our policy committees on October 4th. So we will have the MOAT committee, Market Oversight Committee meeting at 9:30, and the Care Delivery Committee meeting at 11 o'clock to continue the conversation about how we move the recommendations and this great work forward. So a busy fall ahead of us. Thank you, commissioners, and that concludes my executive director's report.
Thank you, David. Before we close, let me open it up and ask whether there are any other comments or questions that any commissioner would like to raise about our scheduling or future meetings. Right. Oh, yes, Commissioner Blakey.
I'm sorry for the late hand, Madam Chair. My question has to do with the reports that we have just released last week, David, on pediatrics. And it may be too soon to gauge this, but I'm wondering what the public response has been to that, both in terms of consumers and in terms of healthcare providers. Have we gotten anything back from that yet?
We have gotten some feedback. It did get a little bit of press attention as well. I think the Boston Business Journal, in addition to the Globe and WBUR, all ran stories. So I think just the fact that the media picked up on it and ran stories is a reflection that this is newsworthy and that the public is interested in it. I will share, without naming names, that we also sent it to a number of state legislators and policymakers who we did receive one comment back that said, I'm so excited to read this report, but I can tell from the title I might be a little depressed after I read it. I think in many cases the report raises some sobering questions, but it's been very well received so far.
Great. I would hope instead of being depressed, people would be energized to take on the issue. But let's hope we can encourage that. Thank you, David.
I do ask that. Other questions? Other comments? Okay, well, hearing none, thank you so much, both commissioners and to all the public who has come in on Zoom. Really appreciate it, and have a good fall.